Let me introduce to you Dr. Carlos E. Barry. Dr. Barry is a psychiatrist with over 25 years of professional experience who is the Associate Chief of Staff for the Mental Health Service line at the Tuscaloosa VA Medical Center. Dr. Barry's practice at the Tuscaloosa VA Medical Center is almost entirely with soldiers and veterans suffering from post-traumatic stress disorder. Dr. Barry is a clinical professor of psychiatry and behavioral medicine at the University of Alabama School of Medicine, Tuscaloosa campus. He is board certified in psychiatry. Also, Dr. Barry is a colonel in the U.S. Army Reserve and has deployed 5 times in support of Operation Iraqi Freedom and Operation Enduring Freedom in Kosovo. So please join me in welcoming Dr. and Colonel Carlos E. Barry as he presents the history of post-traumatic stress disorder. Thank you.
So thank you, Mike, and I'm really excited to be here. I enjoy telling people about PTSD because what we hear and what we see in the media, unfortunately, is often what we're not doing and the bad and the poor outcomes. But we're not here to talk about treatment, but very quickly, we've come a long way. We've come a very long way. So what we're going to do, given the nature of our lecture, is really discuss the genesis of our understanding of post-traumatic stress disorder. And to do that, to start this out with, you're going to see 3 clips from 3 movies. These movies are used without permission, so the quality is not great. The first is The Last Samurai. The second is Wind Talkers with Nicolas Cage. And the third is one of my favorite films, is Courage Under Fire with Denzel Washington and Meg Ryan. If you haven't seen it, you need to see it. I want you all to just see how Hollywood depicts PTSD. You know, these films did a good job of showing nightmares, some of the flashbacks. I left a couple of scenes in where they had a little bit of what we refer to as battle rage. And what I didn't say in the second film, the one with Nicolas Cage, is that the Navajo Indian, who was kind of losing it there on the battlefield, right before that occurred, his friend had been killed, the other Navajo that was introduced in that one scene. So he was all upset because when his friend gets killed, the 2 Indians, the 2 Navajos, find out that the 2 soldiers are there to protect them, but they're also there to kill them if there's any chance at all that they're going to get captured by the Japanese. Because again, their mission was to protect the code talker, but also, more importantly, to protect the code. So if one of the code talkers got captured, he could potentially tell the Japanese about the code, and that, of course, would have proven disastrous. And, you know, historians, and I'm not a historian, but historians say that really won the war in the Pacific. And I apologize. I bet you I went through these slides 10 times, and it never did that to me. They're supposed to be above, but anyway. So, again, I want to thank Mike for inviting me, and thank all of you for coming to listen to me. My other disclaimer is, of course, I have no conflict of interest. And any opinions, other than the facts, any opinions are mine and mine alone, and not the opinions of the VA, the Department of Veterans Affairs, or the Department of the Army, for whom I also work. So, some quick objectives here. I got a little bit of motion. So this was my first trip to Iraq. So, you know, this is a little memento. So, where does the history of PTSD start? Well, actually it starts even earlier than that. About 4,000 years ago, we have some writings from China and the Indian subcontinent where physicians, healers, have written about things that they observed in battle which kind of sounds like what we recognize today as PTSD. So here, 3,000 years ago, we actually have the first concrete writing by this Egyptian who wrote about feeling he experienced before going into battle. And what's significant here is, you know, the concept of the fear, but also the emotional aspect of your soul lies in your hand. You know, think about that image. You know, we all know it increases anxiety. When you go into a war zone, it increases your anxiety. When I have to come up here and talk, you know, my anxiety goes up a little bit. You know, by the end of the lecture, it'll be back down to normal. But you know, you just never know what's going to happen. But the concept of, you know, your soul lies in your hand 3,000 years ago. And then the Greek historian, and if somebody wants to pronounce that for me, I spent a few minutes last night online. Herodotus, so it's a short O. Okay. The Battle of Marathon, 490 BC. This warrior went permanently blind, but nothing happened to him. He was standing next to an individual who got killed. His response to that event was that he developed blindness, even though he was not wounded. And of course, today we would call that a conversion, okay, or psychological blindness. Of course, the movie, The 300, graphic novel turned movie. The commander who kept his men from going into battle because he was concerned that they were psychologically spent from previous battles. Not wounded physically, but psychologically. And the description was that they had no heart for the fight and were unwilling to take their share of the danger. Then there was another soldier during the same battle that was so afraid, so shaken, that they called him the Trembler. What I didn't put on the slide is that the reference that I read says that eventually Leonidas killed him because he was concerned that he was a bad example for the other soldiers. And of course, again, you all remember the battle. That battle was eventually lost. 1,000 years later, not a whole lot had changed. This is Anglo-Saxon literature. Recounts the battle in 1003, the English and the Danes, where the English commander got so ill, and in between, you know, when it says ill, read afraid, fearful, frightened, that he began to vomit and was not able to lead his men. Again, that anxiety that comes with what we would sometimes refer to as anticipatory anxiety that can produce nausea, vomiting. We know that in severe cases of panic, individuals can lose bowel and bladder control. It doesn't happen all the time. You know, it's unusual, uncommon, but it does happen. Now, we know that PTSD, post-traumatic stress disorder, and your trauma-related illnesses are not limited to combat, okay? It's not limited to war. And we've known that for many, many years, actually. So you can develop a post-traumatic response to a motor vehicle accident, to falling down a flight of stairs, to breaking a leg, to a natural disaster, the tornadoes that went through Alabama a couple of years ago, kidnappings, assaults, physical, sexual assaults, etc., etc., etc. So here, in the 1600s, we have an individual writing about the Great Fire of London in 1666. And again, look at the description by this gentleman, Pepys, we'll call him Pepys, a most horrid, malicious blood fire. So great was our fear, it was enough to put us out of our wits. But it goes on to say, you know, his home was not touched by all this, But he wrote in his diary that both sleeping and waking and such fear of fire in my heart that I took little rest. So this is the inability to sleep that we see in individuals with post-traumatic stress disorder, post-traumatic stress responses, difficulty sleeping, they can't rest, they are afraid to go to sleep. And then a few weeks later, he writes about being afraid at night and dreams of fire and falling down of houses. So think of the images that accompany that. And he also writes something that we have come to know now as part of our diagnostic criteria, that for the next few months he continues to have issues. Anger, discontent, and when he heard about a chimney fire in some neighboring place or some place far away, it still put much fear and trouble into him. So this is what we see. So we know that individuals who are traumatized have difficulty dealing with situations. And then we understand nowadays the concept of re-traumatization, where if you've been traumatized, if something happens that is similar or reminds you of your event, it could re-traumatize you and compound your illness and your symptomatology. So, in 1678, a Swiss military physician was the first to identify and name a constellation of behaviors. Okay, so we're talking behaviors, not necessarily symptoms, but behaviors that make up what we now recognize as an acute combat reaction, or acute combat stress, or a post-traumatic stress reaction, or post-traumatic stress disorder. So he called it nostalgia, and he used that to define this condition that was characterized by melancholy, incessant thinking of home, disturbed sleep, insomnia, weakness, loss of appetite, anxiety, cardiac palpitations. Okay? And we're going to see that later in some other descriptions. Stupor and even fever. I can't pronounce the German, but the German doctors called this homesickness. Obviously, it was strongly believed that these symptoms came about because the soldiers were away from their homes. The French doctors took the same term, and they called it, bad French, maladie du pays, and the Spanish, estar roto, I can pronounce that, literally to be broken. So there's this concept that soldiers, when they are confronted with situations in battle, they respond in a way that really damages them. They are broken goods. Here we are in 1727. Soldier wrote about incident in which other soldiers were killed, killed or wounded themselves. And then he goes on to talk about the physical fatigue that caused this inability to understand and much less do what commanders need soldiers to do. And they would get so bad that they wouldn't eat, they wouldn't drink, they wouldn't work, they wouldn't fight to defend the city, regardless of what their command and commanders and their leaders were doing, including being repeatedly whipped for not doing so. So there's a couple of things here. So we know, and we have seen it, and I have seen it, of soldiers who injure themselves because they don't want to go back out to a mission, okay? So it's easier to shoot myself in the foot. I had a guy who shot himself in the foot. Why did you shoot yourself in the foot? Because I don't want to go on another mission. I can't go on another mission, you know? So, and that fear is just overwhelms any sense of responsibility, any sense of duty, and any sense of maybe this ain't the right way to go about doing this. So here we start coming into some history where you begin to see a more defined definition of what we now are beginning to recognize, or what we now call PTSD. And this individual, Dominique Larrey, was famous for many things in the history of medicine, by the way. So I'll start at the bottom. He was the surgeon-in-chief of the Napoleon's armies from Italy, and then all the way up to Waterloo from 1797 to 1815, so 18 years. But what made this guy famous really was this. He established the Army Field Hospitals, a term which we still use today in the Army. He initiated and systematized the first process to remove wounded individuals from the field and get them off the battlefield and into an area where they could be taken care of. And he really increased the concept of having surgeons and physicians in proximity to the battlefield to care for these wounded. So our modern battlefield surgery came about as a result of this gentleman. But he also identified what we now call PTSD as having 3 stages. A period of heightened excitement or imagination. And sometimes I think of that imagination maybe as, you know, fears and apprehensions of what could happen next. A period of fever and prominent gastrointestinal symptoms, which is that anxiety component. And then the frustration and depression. And we know that the comorbidity of depression and PTSD is exorbitantly high, some studies as high as 80%. The same is true for substance abuse. So the 3 films we saw, what's the commonality of all 3 of those films? They were all drinking. They were all drinking excessively, okay? And that is a big problem when we treat post-traumatic stress disorder. So then we come to a little more close to our time, if you wish. King Henry, he writes in his novel, you know, his play, Henry IV, what we now recognize as the 3 symptom clusters of PTSD: re-experiencing, avoidance, and hyperarousal. So if you don't take anything else clinically from this talk today, because we're really not going to be talking about treatment or pathophysiology or biochemistry, but the 3 cardinal symptom clusters of post-traumatic stress disorder are the hyperarousal, the avoidance, and the re-experiencing. And we'll talk a little bit more about them in the historical context. So, the U.S. Civil War brought about the first documented U.S. experience with what we now call PTSD. 2 individuals, Silas Mitchell, who observed what we now recognize as post-traumatic stress in male and female soldiers, and they were self-medicating. Back then, opium was available, but so was alcohol, okay? And there was something interesting in the paper the other day. I didn't read the whole article. I should have kept it. About how alcohol helped prolong the Civil War. They were talking about if the soldiers hadn't had alcohol during the Civil War, maybe the Civil War would have ended a year or 2 earlier. I don't know. It was in the Tuscaloosa News a few days ago. Now, J.M. DaCosta was an Army psychiatrist with the Union Army. And he described and eventually published an article about what became known as the irritable heart or cardiac neurosis, a term that actually was imported to Europe eventually, okay? And the reason he called this cardiac neurosis, neurocirculatory asthenia, soldier's heart, is because of the symptoms. So he documented shortness of breath, sweating, nausea, diarrhea, chest pain, and tachycardia. So if anybody in here, and you don't have to raise your hand, if anybody in here has ever had a panic attack, or if anybody in here has been in an anxious situation, you know that all of these things can happen, okay? one of the hallmarks of panic is that shortness of breath, okay, and the tachycardia, and the feeling that I'm having a heart attack because my pulse is racing. So we nowadays know that those symptoms are part of our diagnostic criteria for generalized anxiety disorder and panic disorder. And he further observed that soldiers could get better if you remove them from the battlefield. So in the Army right now, part of what the Combat Stress Unit does is we have these things called restoration units, where we are set up, usually in your larger bases, where we can take a soldier, we can take Mike, and bring him to my program, our program, and give him 3, 5, maybe even 7 days of respite, where he attends mental health treatment, because we have classes, we have therapists, we have a multidisciplinary team who keeps him busy. They do soldier skills where they build things and have to do things around the base. But for the most part, he's removed from the, quote, fight, unquote, just to let things calm down, just to let him, you know, slow down a little bit. And, you know, our success rate with this type of program is very, very high, very, very high. These soldiers return to their units and return to their original job. So then we had World War I. So we all know that World War I was a devastating war in terms of the face-to-face conflict, the face-to-face combat, the way we fought the war, okay? Not to say that World War II or Vietnam was less devastating, but World War II was a World War I was a brutal war, and the way we fought it, you know, we were still fighting wars the old way, where soldiers would line up 100 yards from each other and shoot at each other, and then charge at each other and hack them up with bayonets and stuff. So the term shell shock came about. And initially, shell shock was believed to be a result of the blast effect. Now, can we have problems from blast effects? Sure we can. Guess what? A lot of the TBIs, traumatic brain injuries, we see from Iraq and Afghanistan are blast effect. Not necessarily rolling over in that Humvee, it's rolling over after that shock wave, whether it's an IED or an RPG, a rocket-propelled grenade, or whatever else hits your vehicle. Okay, that shock wave in and of itself produces a tremendous amount of damage. But, of course, World War I was famous for its chemical warfare. You know, part of the eventual, and I don't want to say what the name of it is because I don't remember, but part of the convention after the war was to limit the use of chemical warfare, because the damage that mustard gases and other things did during World War I, and the contamination and the spill out, the collateral damage, which is the term we use nowadays, with the civilian population and everybody else was really incredible. So at this time in World War I, these symptoms were considered odd and unfamiliar, and you know, they were eventually found to be psychological, meaning not related to the shell blast or the gas, and it was called war neurosis, which then eventually translated into shell shock, or was called shell shock. And again, look at the symptoms: agitation, fatigue, this increased startle response. So I mentioned the 3 symptom clusters of PTSD. One of our clusters is hyperarousal. Hyperarousal is exactly that. That's a big part of it right there, okay? So if you all have a friend or a relative or a family member or somebody you've seen who really jumps when a car backfires, cars don't backfire now as much as they used to in the old days because they're all, you know, computer controlled. But you slam a door, or thunder goes off, and you see people jumping. or, you know, a gunshot goes off. That increased startle response is very typical of a post-traumatic stress reaction. Loss of concentration. This is something that has been studied and studied and studied because we don't really fully understand why these individuals have so much cognitive impairment. Okay? Mood lability. The term lability, everybody knows what that means. Lability is the ability of your mood to shift easily and involuntarily if you wish. Okay? So sometimes in response to external stimuli, but sometimes in response to internal stimuli. So it's very typical, very characteristic of your manic depressive disorder patients, what we call bipolar disorder. So they have this quick and rapid fluctuation of their moods. And then they also saw conversion reactions, which include a loss of sensory and motor function. And of course, the soldiers weren't able to fight. So in 1917, Dr. Rivers published in the British journal Lancet a description of war neurosis. And he attributed this to repression. Now, again, repression is a psychoanalytic term. It's one of the defense mechanisms that was put forth by Sigmund Freud in his theories. Okay? And repression in psychoanalytic world is the defense mechanism that is often seen or used to explain depression. Okay? And you can see that the description is that these soldiers are mentally withdrawing. But he also noted, just like earlier, that these soldiers can get better, okay, if you take them off the battlefield and treat them. And back then, by the way, our treatment was barbaric sometimes. We used cold packs. We used laudanum. Laudanum is a opiate derivative, if I remember correctly. If not, somebody it is. We didn't really have a whole lot of pharmacopoeia back then. They used opium. So then World War II comes. So they start looking at 4 factors that causes this battle fatigue or this war neurosis. Sudden exposure, cumulative exposures, physical stressors, and home front issues. Well, guess what? Here we are in 2012. So what do we know today? Let's get rid of the word sudden. We know that exposure to a traumatic event can lead to the development of a trauma-related disorder and post-traumatic stress disorder. Okay? Guess what? We fully now understand the concept of re-traumatization. So when we talk about war, let's talk about OIF and OEF. You have soldiers who are being deployed 2 and 3 and 4 times. Is that a good thing? Well, you know, from a mental health point of view, no. Because even if that soldier isn't exhibiting signs and symptoms of post-traumatic stress disorder, guess what? The fact that he's going back into combat after sometimes only 1.5 years or 2 years of dwell time at home is what we would call re-traumatization. Okay? Same thing, let's bring it to the civilian world. So if you have somebody, a sad example, but to make the point, if you have somebody who's being repeatedly physically assaulted, a battered wife or a battered husband, and doesn't get away from that assaulter, that batterer, that re-traumatization is just cumulative. And we understand now really makes things more difficult for us in terms of treatment. Physical stressors contribute, you know, the physical demands of being in a battlefield. And of course, home front issues are a big, big problem and contribute to the development of illness. So the development leads to your symptoms. And these are symptoms which were described after World War II. Fatigue, memory loss, again, anxiety, loss of concentration, depression, and physical problems. So the common thread as we move forward is we still have, if you want to pull these things out, it's the same kind of cluster of symptoms with some significant cognitive issues, which, again, we're still looking at today, trying to understand why. We know they occur, we're just not fully sure why they occur. So during World War II, the focus was returning soldiers to the battlefield. And that is still our doctrine nowadays in the Army. Okay? If we sent everybody home that came to a combat stress unit, so my last time in Iraq in 2009, I was seeing 20, 22 people a day. Okay? So think about sending those people home 7 days a week. We wouldn't have an army to fight. And I was just one provider. There was other providers, other psychiatrists throughout, the country. So, back in World War II, they recognized the concept, which is part of our combat stress doctrine now, which is brevity. Brevity refers to keeping treatment short and simple. Okay? So, again, that's going back to my restoration unit. Mike comes to my restoration unit. I'm not going to keep him for 28 days or 2 months or 3 months. I'm going to keep him for 3, 5, 7 days and send him right back where he came from. So then we talked about medication. So now World War II, so we have discovered the barbiturates, we have discovered amphetamines, we have discovered insulin, we have discovered ether, and they were using it to treat our soldiers. That's really helpful, huh? So insulin, for those of you who don't know, insulin shock was a standard treatment in mental health way back in the 30s and 40s. It would be unheard of, unethical, criminal nowadays. What you do is you inject somebody with insulin, you drop their blood sugar low enough and they go into shock. Think about it. It's barbaric, but that's what they did. Some people would say that the way we do ECT nowadays, electroconvulsive therapy, is still barbaric. And that's a whole different lecture, but I will stand here and tell you that it is the most effective treatment we have for depression. More effective than all of our medications. During World War II, and some of these images could be a little disturbing. During World War II, we saw, again, incredible devastation, not just in Europe, but in the Pacific theater. It's unfortunate that this kind of event has to happen to move science forward, but it did give us an opportunity to really move military medicine forward. The same is true for this war we're still fighting. We have made some incredible advances in military medicine because of this war. So, concentration camps. Again, we know the history of it. I'm not going to go into the history, but there was several individuals who wrote about this. One of the most famous is Viktor Frankl, who was a concentration camp survivor himself. He was an Austrian psychoanalyst who had studied with Freud and was in a concentration camp, and after the camp he wrote this incredible piece of work, From Death Camp to Existentialism, and he is considered the father of the existentialist school of thought, or school of psychology. Okay? Robert Lifton wrote about the experience in Hiroshima and the survivors of the Hiroshima and Nagasaki bombings. So, in the civilian world, so let's go back to the civilian world. So you can see the newspaper clipping there. 447 people died. Okay, so this was a nightclub fire that occurred in 1941. They were in this big nightclub, and the doors, the few doors they had been chained or barred or locked or boarded up. So there was no way to get in and out except the one entrance. So fire broke out in this club and 447 people died. Now, what it gave us an opportunity to do was to work with the few survivors of the fire. There have been several events over the years that have given us this opportunity, that opportunity to work with survivors and try to look at the development and the genesis of the disease, post-traumatic stress, and look at individuals who get treatment versus those who don't get treatment. So I'm looking around the audience. Most of you look like you're old enough to remember the Chowchilla bus incident, 1975, if I remember correctly. So these three guys in California decide to kidnap, take hostage a bus, a school bus full of kids that were on some outing. And they take the bus, they hide the bus, they put the kids in a van, they take the van, and then they bury this van in a trench that they had dug out in the desert in California. And then they wanted the city of whoever, Sacramento or wherever it was, to pay them money. Well, the kids, the people, and one adult in the bus who were now in the van were able to get out and dig themselves out of what really amounted to a hole that had very little dirt on top of, fortunately for them. And the three guys got caught, and actually just a few weeks ago there was something in the newspaper that one of those individuals got paroled, okay? But it has given us an opportunity to follow these children and the one adult, the bus driver. It has given us an opportunity to see who has and who hasn't developed symptoms, those that received treatment versus those that didn't get treatment, how it has affected their family. We also saw the severe floods from Hurricane Hugo in the Carolinas. Those of us who were around remember seeing images of bloated cows and bloated farm animals because there was so much water that had taken over fields and stuff. And it devastated huge regions of the Carolinas. And there's a group, I think at Duke, that is following some of these survivors. So some incidents like this, tragic as they may be, give us an opportunity to further, our science. So, going back to here, so for the first time, the DSM is the Diagnostic and Statistical Manual. This is a manual that is put out by the American Psychiatric Association. And the first DSM was in 1952. And research done as a result of this fire led to the recognition of psychological trauma and the inclusion of this kind of syndrome in the first edition of the DSM. So then we move forward. I have a copy of the DSM-2 and the 3 and the 4 and the 4TR. I don't have a copy of the DSM-1. So in the DSM-3, which came out in 1980, for the first time, the term post-traumatic stress disorder is included and establishes some criteria.
Excuse me, do you know what it was called in the DSM-1?
No.
Okay.
If you give me an email, I'll find out and let you know.
Okay, sounds good.
No, I don't. That's a good question. So, 5 elements. You got to have a stressor. You got to have a stressor. So something has to happen. At least one symptom of re-experiencing, 2 or more symptoms of numbing or reduced involvement in the world, and then miscellaneous symptoms, which includes your substance abuse and your depression. No minimum duration, no acute form, no chronic form. So, let me try to wrap this up. So, now then would come Vietnam, okay, which was actually right before 1980. But this is, I picked this study because this is really the hallmark study of the Vietnam veteran population, looking at the individuals who had PTSD at some point during their lifetime. This study was put out in 1983. The Vietnam War came to an abrupt end about 1975. And since then, there have been numerous studies that have replicated those studies with the Vietnam vet population. And then this study was the very first study that really took a look at our OIF population in terms of what was happening to them when they returned, and the prevalence of mental health problems reported. So, that's kind of the genesis. I think I'll leave it there and open it up to questions, comments, thoughts. And thank you all.